Yeah, so I'm in the western suburbs out near Kenmore mostly. Been a physio for, it's just gone 5 years now. I'm probably in the men's health space for about 4. Yeah, so it's see a lot of blokes pre and post prostate cancer journey, particularly those that have had radicals. Yeah.
Yeah, awesome. Now, Tom, you did mention beforehand, with absolutely no spoilers at all, that you had a very interesting story for how you got particularly interested in exercise and below the belt activities. So can you please share your story with us?
Yeah, I suppose I can't remember which story I told you now, but basically when I was at uni, we had a hell of a lot of women's health lectures and basically no men's health lectures. And so I was kind of like, if I'm graduating and don't know any of this, then most blokes probably won't know anything either. So basically started from there. And then, so I've always been biased towards exercise in terms of other modalities. And then, it's led on this discovery journey and hitting the research and seeing what's out there.
All right, awesome. Thank you for joining us specifically to share that research. And we'll talk about the research around erectile dysfunction exercise in general, but for post-prostate cancer in particular, I think the first question I'd have is around, the exercise in general for erectile dysfunction. What does the research say?
Yeah, so there's a lot of, there's been 2 systematic reviews, which for those who don't quite know, it's basically when researchers get a whole bunch of smaller and larger studies and compile them together to see what happens when you have a larger population. And there's been 2 of them published in the last kind of 12 to 18 months, and both of them have both heavily favoured exercise as a form of treatment for erectile dysfunction not related to surgery. So in terms of general erectile dysfunction not related to surgery, the evidence is really good. Aerobic exercise really, really benefits men to help either regain full erections or make it better.
Okay.
Yeah.
What kind of exercise are we talking here? Is this sort of a general any cardio, or so I think most people know of Kegels when they think erection-based exercise.
Yeah, so interestingly enough, 6 of the 7 were just aerobic exercise. So going for a good walk, getting on a bike, whatever the patient could manage, basically. And it was aerobic exercise of what's deemed a moderate to vigorous intensity. So the realistic thing, which I'll probably hammer home later on, is intensity is the key. So going for a walk where you're not out of breath, you're not puffy, you're not hot and sweaty, you're just casually strolling out the shops, it's not going to be enough. It needs to be more than that.
Okay, and so that's for erectile dysfunction in general. I'm wondering if it's specifically for post-prostate cancer surgery, because I know I'll have quite a few people who are listening in the chat box and do say hello if you relate to this. Is there any literature showing for that in particular, there's certain exercises that will benefit?
Yeah, so quite surprisingly, there's basically been no studies looking at exercise as a form of treatment post-prostatectomy. So even looking into the definition of penile rehab is defined the use of any drug or device after radical prostatectomy to maximise erectile dysfunction recovery. And in that definition, exercise isn't even mentioned. So again, there was a Cochrane review, which is like pretty big up in the systematic reviews this year released. And in terms of penile rehab post, there's really no evidence, there's no studies that have been done directly looking at exercise to enhance recovery. But there's a hell of a lot of overlap. So when we kind of talk about what happens post-prostatectomy to the penile tissues and everything else, and then systemic changes with exercise, there's a hell of a lot of overlap that there would be benefits in exercising to assist along that journey.
Yes, I find that fascinating. There's not been systematic research on this, just from my own one-on-one experience with clients. And Sean Bundy has just come in and said intense walking helped him. Just anecdotally from patients, they've said, sonosurfing has helped them certainly feel a lot more energetic, which then has impacted their sexuality. And that aerobic and cardiovascular exercise seems to, in my mind, make sense considering an erection is a cardiovascular event. So that's really interesting.
Yeah. So 100%. So in terms of if we get into like the nitty gritty of erections, you basically need the smooth muscle to be working. And post prostatectomy, we have damage to the nerve, which then changes the blood flow. We get a loss of blood flow to the penis, and then that causes changes in the smooth muscle around the penis. So over time, we get what's known as fatty infiltration, which basically makes the muscle not as good as it once was from under usage, essentially, which then changes the way that the tissues is able to utilize nitric oxide. The nitric oxide is one of the keys for erections. That's what causes the blood flow into the tissues and helps with everything like that. So exercise in general does all those things. So decreases the fatty deposits in the muscles, really opens up nitric oxide, gets a lot of blood moving all around the areas.
Yeah, and just had Alan share that. I think he's saying for him that he's found that regular exercise has also helped with libido. Thank you so much for sharing that, Alan. I found this in my practice as well, that it's libido and sex drive that it can also be impacted by exercise, not just the erection. Tom, have you found that too with when you've helped men get into exercise?
Yeah, definitely. So we know exercises increases testosterone levels, which is a key driver of sex drive and libido. And you also get release of all your happy endorphins into the brain. So you feel, everyone's probably heard the term runner's high. So that's essentially what happens when you exercise. You get a whole bunch of endorphins and you feel pretty good. I think I mentioned to you earlier, Victoria, about how I had a patient who was given a whole bunch of tablets to take and came in and was like, oh, it just doesn't work. And I said, well, how are you using them? And he's like, I just take one and basically sit there and watch and kind of expect something to happen. And then I was like, it's never going to happen. So we got him to go and exercise and do stuff that he enjoyed to feel good about himself. And he was able to achieve a lot more afterwards. So just by being in the mindset that he felt good, happy about himself, because he'd gone and exercised, he was able to achieve a better result with his erectile function.
Hey, Tom, now was this somebody they popped a Viagra and you got them to do a few push-ups, or is this sort of a general exercise regime that then you felt over time impacted?
No, I think he, from memory, I think he was a bit of a golf player, and so he hadn't gone and played golf because he just didn't want to go out of the house. So once his continence was under control, he was moving along the erectile or the penile recovery halfway. So I basically said, go play golf a couple of rounds a week. So he was out walking, playing golf, back with his mates, feeling blokey again. And then that's kind of along the way. So it wasn't just one round of golf. It was a cumulative over a couple of weeks that he started to get better results.
Great. And it sounds like with him, you worked on finding what he enjoyed doing anyway. I'm wondering, when you put together an exercise regime for somebody who specifically is looking for this to have an impact on erectile tissue, on their sex drive, what would you recommend? How would you go about that?
Yeah, so it's always, I mean, the general phrase is the best exercise is the one that gets done. So it's usually trying to take into effect what the person likes to do. And then, I mean, it always depends on where they are as well on their continence journey, because sometimes they can't do as much without having effects there as well. So one can affect the other, definitely. So always trying to find what the patient likes and what they previously enjoyed doing and start there. And then basically, often, unfortunately, that's usually not quite enough. So that's our starting point, but we need to get to here, essentially.
Yeah, and you mentioned intensity is important before, and I know that's now on my mind. I'm sure some other people's too. So what kind of intensity are we talking here? Say, what would minimum exercise a week be, and how intense?
Yeah, so one of the studies had really good guidelines, and they're actually really pretty similar to the Australian current exercise guidelines. So they actually recommended supervised for the first 6 weeks. So going and actually doing it with someone, and then switching away from supervised after that, so after a period of 6 to 12 weeks or so. And it was minimum of 40 minutes of moderate to vigorous intensity 4 times a week. So that's slightly, a little bit less than the Australian guidelines, but around that, that's kind of as seen as the minimum. And when we talk moderate to vigorous intensity, the most simplest way to try and think about it is you should be a bit hot, you should be a bit sweaty, you should be a bit puffy. So you shouldn't really be having a really in-depth conversation with your spouse. It should be short words, really short sentences, not kind of one-word answers, but really kind of sucking in the big ones in between sentences. That's kind of the easiest way to know when you're up into that intensity zone where the magic happens.
Great. And you mentioned so supervised for 6 weeks. That's so that somebody as well can try and have a conversation, make sure you can't ever have a conversation with them. I'm wondering, how would somebody go about finding supervised exercise?
Yeah, so unsupervised, it's again, it's a huge scope. Some people that are listening probably have no other comorbidities. Other people listening probably have diabetes, cardiovascular disease, or both, or more, or asthma, or something like that. So it is a tricky one. It does need to be fairly individualized because, again, like my high intensity would be higher than someone else's, but lower than someone else's, just depending on how much they've done in the past. So the hot, sweaty, and puffy is a bit of a general guideline, but for a lot of people, 40 minutes of that, and they're going to be cooked for a couple of weeks. So it's building up to that, which is essentially where the supervision comes in. So there's normally a couple of simple little step tests wearing a heart rate monitor. Heart rate monitors are incredibly cheap these days. Like you can pick up a Fitbit for about $90, which will give you a guideline of your heart rate, and that's usually the best way to track it. So knowing where a safe place for you to work out at in between is definitely the safest way to do it.
Yeah, we've got Fiona asking here, how about an accredited exercise physiotherapist? Is that a good idea? Because it sounds like you recommend supervision from at least having the Fitbit to monitor what you're doing. What stage would you recommend for an exercise physiotherapist?
Yeah, so exercise physiologist. It's
there you go, physiologist. Thank you for the correction.
Confuses everyone. No, they're another great place. So if you've got no injuries, you're fairly healthy, exercise physiologists are great because that's their bread and butter, is getting people exercising in safe and comfortable ways. So I can't recommend them highly enough. When to do it, essentially when continence is pretty good, when you've had the all clear from the surgeon, and you're in the kind of, recovered from the mental side of things and you're mentally ready to start having a crack. There's no 4 weeks, 6 weeks, 4 months or anything like that yet that's been established as the best time to do it. But the quicker you get in, definitely the better.
Great. So it sounds like the message that so many of these conversations come down to is that everybody is different. So finding your own individual path and best kind of exercise is important. I know from my conversations with people as well, there's so many other factors that can influence whether something that is behavioral like this gets done or not. We all have, I know myself, got great exercise intentions and then life just happens. Life gets in the way, or I get like a little injury and it knocks me to the side. What if somebody's in that position where they sort of feel like, look, I'm really busy, don't even know how I'll find time in the week to do this. What do you recommend they could start with?
Just starting with the simplest things at home. Just crawl out of bed, do some squats, do some push-ups, do something like that, something really, really simple. Or if they're still working, they'll get off the bus a couple of stops earlier. Trying to make it part of the day is a good starting spot, definitely. And look, we say 40 minutes, but that's essentially the goal, is to get to 40 minutes. So there might be 10 really, really short bursts of fast walking around a farm, for example, 4 times throughout the day, paddock to paddock or something like that. So there's always a workaround. I get a lot of excuses, and there is a workaround. It's essentially how you want to do it. And I made a note here before about the best part about all this is if you've got a bit of an injury or something and you go and see someone, you don't need to tell them that you want to exercise because you want to be able to get better erections. You can just go in and say, I've got a dodgy knee. No one needs to know the backstory as to why you're hell-bent on getting your knee better so you can exercise. But you can just go and see someone, have a chat. Hey, I hear, these are the guidelines that I should be working towards. How do I get there with this dodgy knee? And there's 1,000 ways to skin a cat.
Yeah, I want to know actually. So, what kind of excuses do you tend to hear, and what sort of clever workarounds have you come up with?
Yeah, the time's always probably the biggest one. So yeah, time's always an interesting one. So normally you start with kind of, how much time do you spend watching TV at night? And what if you went to bed, half an hour early and got up half an hour earlier? And just starting with simple changes like that. It's quite interesting. Often in this kind of landscape, you can often the wives will jump in and righto, we're both getting up, and that seems to get things kick-started. So normally trying to involve the spouse or something like that often helps as well.
Yeah, we've had Fiona share that herself from the chat, saying that bonding wise, I think she's saying she's found it useful to be involved in the exercise routine too. For that similar aim as well. Yeah,
definitely. The other one is often the younger guys, tradies and farmers and blokes that tinker in their shed all day. The reality is that's part of your job, or that's part of your daily activity, but it's not the same as exercise. So yes, you may be walking around the farm all day, every day, but your body's accumulated and got used to doing that. So that's just part of your daily activity. If you want to get further and better results, you still need to do a bit more higher intensity exercise. Like we said before, you can put that into your day by walking faster between paddocks or things like that. But you still need to do more. And tradies are the same. Tradies are often, but I'm on my feet all day, up and down ladders. But your body accumulates and gets used to that. So it doesn't quite count as exercise anymore.
Yeah. Well, we've got a question that's come in from S-Man. Are exercise physiologists liaising with urologists to understand the exact nature of treatment? They're saying, for example, nerve sparing versus non-nerve sparing surgery. And so let me know who has asked this in the box. This is correct. I think they're essentially asking, well, if the goal is for erectile function, would an exercise physiologist or someone like yourself be looking at details like that, whether it was nerve sparing or not nerve sparing, in order to put a treatment plan together? Or does it tend to be the same guidelines?
The guidelines don't necessarily change. They stay the same. So there's, in terms of education, in terms of like across all the unis and everything, men's health and prostate recovery and education across that on the whole is quite low. So there's smaller courses popping up here and there to try and educate people, and some people will just take an interest and just start getting involved, but there's a lot that kind of won't. So the only time that it can be an issue is if someone, for example, has had like a sling put in for urinary incontinence. There's a couple of recommendations of what not to do with those devices, but otherwise, once the surgeon's given you all clear that you can go back to work and do everything else, then it's just seeing someone, starting slow and just building up to that, and most people would be fine.
And now we've got a text that's come in. I think it might be the same one that's on my mind, so I'm just going to fetch this now. And somebody's wondering, I think we've mentioned this a couple of times. It's that, what type of exercises to suggest. So maybe say somebody came to you and said, look, I'm happy to do any kind of exercise at all, as long as it's really going to be the one that's best for erectile function. If you put together a regime for that person, what would that look like?
Yeah, so it would be a combo. So weight training is, as much as a lot of people don't really like to go straight to weight training, the systemic effects of weight training are absolutely huge. And particularly for blokes, when blokes start lifting weights, they feel so much better about themselves that definitely helps. So it would involve a session or two a week of weight training, and then aerobic exercise, which would be walking, riding, swimming, you name it. So whatever they're happy to do. If they've got a bike and they like riding, bike riding. If they just want to walk, they'd be walking. And they'd be building towards doing a bit of interval style training into that walk. So walking really, really quick for example, 30 seconds, and then slowing down to a moderate pace for a minute and a half, and repeating that for a period of time to get more bang for their buck. So that would cover the aerobic and the strength side of things. And then, yes, the pelvic floor exercises are still important for erectile dysfunction. So essentially, the pelvic floor muscles play a crucial role in penile rigidity. So an efficient contraction helps increase the pressure inside the penis, so keeping the blood flow in. Interestingly enough, most of the studies on erectile dysfunction and pelvic floor exercises based towards the pia erectalis muscle, which is essentially your bum muscle, so which is the tightening of the bum muscles, trying not to let a fart escape. Those kind of older style exercises, which we don't really encourage anymore for the urinary incontinence side of things. So there's a bit of a kind of trade-off here. So early days, incontinence is normally more at the forefront of men's minds. So we advocate for seeing someone and learning how to advocate to activate the anterior pelvic floor muscles. And then once incontinence is coming under control, then start to try and engage the back muscles, essentially pia erectalis, to then help with the erectile side of things.
That is very interesting, Tom. So is it what you're saying, that when incontinence is the goal and that's the focus, there's a totally different area of the pelvic floor that you're encouraged to focus on, but then after that, and erectile function is the key goal, these bum muscles need to come into play? And is it that when should men be doing that kind of exercise? What does that involve?
Yeah, so it's an interesting little trade-off which I found diving into this over the last couple of weeks. So the last couple of years, some guys at UQ up here, Ryan Stafford and Paul Hodges, have really dived into why do blokes leak after having a radical prostatectomy, and their research is heavily showing that the anterior muscles are the main ones that we want to activate. But in terms of the erectile dysfunction research, it's all mostly heavily based towards the bum muscles. Now, that may change as we do more research and find that, in fact, you can do the front ones and still get better outcomes for erectile dysfunction. It's just the research hasn't been done on the front muscles and erectile dysfunction. So that may come, but essentially the reality is when I'm talking about patients, it always comes across as quite black and white, but it's not. The reality is it's a whole functional unit. So the three muscles plus your breathing plus your tummy and abdominal muscles, it's all a functional unit. So while we try and bias one area, they're all important, and it's essentially more how they play together is the important part.
That's great to know. Now I'm wondering, look, if somebody was, say, when they had taken Viagra and they were really hoping for that erectile response, or maybe they've used injection or a pump, is there anything they actually could be doing with these particular muscles? You even mentioned breathing and the abdominals that they found could actually impact and help the erection in that moment.
Yeah, so doing some pelvic floor muscles during, like while they are waiting for a tablet, for example, to take effect, can help kind of hold the bit of blood flow in there. With the injection, it'd be the same. So you could try and, you wouldn't be trying to necessarily squeeze as hard as you possibly could, but just trying to activate the muscles there to encourage them to do their normal role of being a bit more toned to help hold the blood in the penis.
Sure. And so this is the pelvic floor that we were talking about before, or are we back to squeezing the arse? I'm imagining there's so many blokes that are now going to be squeezing everything possible from below the belt.
It's never, we try not to think about it as strength too much anymore, and just light activations, because they're not normally, essentially they're working pretty hard during orgasm, but the rest of the time they shouldn't be working super hard. So if you're there taking a tablet and you're squeezing the bejesus there, everything is probably not going to be the best for you. It's better off just light kind of rhythmic contractions while you're waiting for things to take hold, and then hopefully you start thinking about other things.
Okay, great. We've had another question come in from Doug from WA. I think he's wondering, sort of, when we talked about this being as a part of penile rehabilitation, he's asking, if you're doing lots more exercise, would you need to continue with taking Viagra? What about using a pump as well? I mean, my thinking, and what if that's the same as yours, is a lot of this is a very holistic approach, and doing a little bit of everything is usually better than focusing on one thing. But I'm wondering, have you found anything in the literature? Otherwise?
Essentially, the literature is really lacking in this part. So the fact that it's not even mentioned in the definition of penile rehab, to me, is a bit of an issue. The interesting thing, which I found in one study, was taking Viagra and things like that, it doesn't actually change the actual smooth muscle tissue in the penis. So it'll allow you and bypass mechanisms to get an erection, hopefully. But the actual structural change in the epithelium, which is the smooth muscle around the penis, it actually doesn't change. So you may be still achieving erections over the next 12 to 18 months using Viagra, but there hasn't really been a change there. So the only kind of thing that there seems to be, now not direct evidence, this is kind of synthesized and like thinking it through, but the only way that you can kind of imagine getting some change there is reasonably intense exercise, where we get those systematic changes throughout the smooth muscles, throughout the whole kind of body. So,
right. So is it that while we're lacking in specifically post-prostate surgery, we're lacking in evidence around exercise affecting muscle tissue there, but we can see in general, systemically, general aerobic exercise and the regimes you've described do help the smooth muscle tissue in a population of men who haven't had surgery. Is that correct?
That's correct. Yeah. So in a healthy, I shouldn't say healthy, but in a non-operated group of men, yes, we see these effects systemically, and you would imagine that it would be happening to some extent. It may be reduced post-prostatectomy because of the neuropraxia down there, but you would hope, and hopefully we can get some research done sometime soon to kind of show that it does do it. I'm pretty biased towards exercise, so I would imagine that it would definitely be doing something. How large that treatment effect is, time will tell. But yes, systemically, we get these epithelial changes, we get less lipids and fat in the blood, helps with your diabetes, and all that stuff will affect the smooth muscle in and around the penis. So if we can get rid of all that yucky stuff out of the blood, promote nitrous oxide, try and look after the smooth muscle tissue, going forward with the tablets and everything else, we should be getting better results.
All right. So even you mentioned it could actually, general exercise has been shown to promote nitric oxide, which is, so that's a transmitter, the chemical that's released by the nerves that are surrounding the prostate. Is that correct? Yeah.
So that's released around the penile tissue to open up the blood vessels, get the good blood in, and then close it out essentially.
Okay, well, I agree with you. It's interesting that the research hasn't been done in that area. This is so similar to lots of other areas of erectile function in general, but especially where it's most needed in the post-prostate surgery case. Got a couple of other questions coming through. We've got about 2 minutes to end, so we'll probably end with these ones. Somebody's asking, it'd be great to know whether exercise of the abdominal and the lower abdominal muscles would help to improve erectile function. What do you say from your experience, Tom?
No. Essentially, if a bloke's hell bent on having a six pack and everything, and he feels that by doing abdominal exercises, he feels a lot better about himself. So getting on the floor in the morning and doing 200 crunches, and that's how he feels really blokey. That'll help from the psychological side of things, but you won't get enough blood flow in the whole body, and your heart rate won't get high enough, and you won't get the systemic effects of exercise. So from a psychosocial point of view of feeling better and more masculine, that side of things may help. Systemically throughout the blood system, not a bad thing, but I'd probably spend my time doing something else.
Yeah, it sounds like you mentioned before. So there's sort of these two sides to this, the exercise. There's the actual, when you're doing weights or intensity and it's aerobic, that's what's really helping the body the most, and the erectile function. But then, of course, the erectile function is always helped by addressing that psychosocial piece of just feeling sexual, feeling in control, feeling masculine. That's really interesting to keep coming back to the two. Got a final question here has come in. What is the evidence of exercise for non-operated men with diabetes who have erectile dysfunction?
Yeah, pretty good. So should be kind of definitely advocated as like a first option. So yes, essentially the better controlled the diabetes is, particularly with exercise. In that systemic review I talked about, there was 2 of the studies, the cohort was men with diabetes, and within 6 months they all improved their, well, not all, but I shouldn't say all. I think it was about, from memory, 70-odd% saw an improvement in their erectile function within the 6 months. So,
great. In conclusion, exercise is great, but it's great also in areas that we may not be thinking about. We may not think about general aerobic exercise, or even the idea that weight training would have an impact on what is going on downstairs. And I know there's so many men I speak to who would love any advice for how they can make the Viagra more effective, or any of their other rehab strategies more effective, and general exercise potentially is absolutely being overlooked. So thank you so much for joining us, Tom. Now, Tom, if people want to get in touch with you, maybe for an appointment or to have a further chat, what's the best way for them to do that?
Probably email me at tom@menshealth.physio. There's now a menshealth.physio website. And with all the stuff that I've gone through, I'm going to try and put into a nice, simple little infographic. So just showing the systemic effects of exercise and how it relates to erectile function, now that I've got it all nicely kind of synthesized on a couple of pages. And then I'll give that to Victoria to email out as well.
Wonderful, wonderful. That's wonderful for you. I think we'd all really enjoy that, and I'll email that out once that's created. Thank you so much for joining us, Tom. It's been great.
That's all right.
Any final thoughts or anything that you just would love to share?
No, I think the main thing is, start with what you can manage and then build. So the intensity is definitely part of the key. Go and see an exercise physiologist, a physio. Go and see whoever you enjoy working with, and then just build the intensity. Try and get to that 40 minutes a week, 4 times a week. Do your pelvic floor exercises, and just it's not gonna happen overnight. It'd be fantastic if it would, but it's fantastic for you anyway. So if you're gonna do anything, exercise.
If you're going to do anything, exercise. Thank you so much for leaving on us, Tom. Thank you for joining us.
That's all right. Thank you.
Bye.